Welcome, and thank you for joining us for the first webinar in a two-part series, Advancing Sustainability Research in Cancer Control. My name is Denise Gnip, and I'll be your WebEx host. Before we get started, I'd like to review a few WebEx logistics. This webinar is being recorded and will be available on the IS website in the coming weeks. All lines have been muted upon entry and will be in listen-only mode during the webinar. Please submit your questions and comments by using the chat or Q&A panel and select everyone or all panelists before hitting submit. The moderator will ask them on your behalf during the Q&A discussion. You may need to activate the appropriate panel using the three-dot menu found in the bottom right corner of your screen. To focus on the people who are showing video during a meeting, click on View in the top right corner, choose Hide Participants Without Video. Lastly, closed captioning is available by clicking on the CC button, and you'll find that in the lower left corner of your screen. And now I'd like to hand it over to Dr. David Chambers to begin the meeting.
Thanks so much, Denise, and thanks everybody for joining us. We are, as always, pleased to be with you and engage in a conversation about areas within implementation science that we think are both through which we're making progress and for which there is still work to do. And so glad that all of you are joining us today. You can see the smiling faces next to mine are three wonderful speakers who also happen to be incredibly successful examples of fellows who have done different fellowship programs that I've had the opportunity to interact with over the years. And it's just so great to see how their careers have blossomed from those fellowships, well, even before, but from those fellowships onward. And so just giving you a sense of what we're going to be talking about or who you're going to be hearing from. Maggie Correa Mendez, who will speak first, has been a cancer prevention fellow with us in the past, and then we've seen her launch into a really exciting opportunity with our National Cancer Institute Center for Global Health. Ginger McKay next to her, who I had the pleasure of meeting back in 2016 when she was one of the fellows in our training institute for dissemination, implementation, research, and health. Saw the work that she was doing in HIV, saw some great work that she was presenting around de-implementation, and then now doing more work around sustainability. And then Ramsey Saloom, who I met in that same year, 2016, when he was a fellow in the mentored training, MT-DIRT, mentor training for dissemination, implementation, research in cancer. And so hearing from Maggie about this great review that she's been doing, and then hearing from this wonderful work that Ramsey and Ginger have been doing both in domestic and then in international settings will give us all a chance to think about where sustainability research has been going and where it could head in the future. So we're going to hear from each of these speakers in turn, and then as Denise said, any questions that you have, please submit them as we go, but we'll be able to take on as many of them as we can. So not wanting to take any further use of the time, I'm going to turn it over to Maggie, who's going to kick us off with reporting on this portfolio analysis.
Wonderful. Thank you, David, and thank you all for joining us today. Today, I'm going to share very briefly some key findings of a portfolio analysis that we did, including implementation science grants that were funded by the National Cancer Institute that proposed to study sustainability of evidence-based practices, programs, and policies for cancer control to really help us understand better what has been funded and identify opportunities for research. Next slide, please. And so two analyses that really served as the basis for the work that we did. First, a portfolio analysis of NCI-funded grants, which pointed out that out of the 71 awarded grants included in the analysis, only 7 studied sustainability. Then there was an analysis that explored R01 grants in the US-based R01 grants funded by NIH broadly between 2004 and 2016. Which found that out of 84 projects, 51 made reference to sustainability, but then only 3 grants focused on studying sustainability exclusively. Next slide, please. And so with this in mind, and to build on the previously mentioned reports, we conducted a portfolio analysis to provide an overview of implementation science grants awarded by NCI between 2017 and 2023. That study the sustainability of evidence-based practices for cancer control. It is important to mention and clarify here that we broadly capture grants that study maintenance, sustainment, and sustainability, and we wanted to use a broader umbrella term, so to say, to include as many of these grants as we could analyze. Through our analysis, we also wanted to describe the approaches to study, measure, and or plan for the sustained use of these EVPs, as well as identify gaps in the current portfolio and highlight opportunities for research. Next slide, please. And so we informed the data that we wanted to capture, or code book, so to say, based on key considerations or research questions for the sustainability agenda. We first wanted to capture how these grants are proposing to study or examine factors that affect sustainability. We wanted to capture if researchers are proposing to identify and evaluate strategies for sustainability specifically. And today we're going to hear about two great examples around identifying strategies. We also wanted to capture the measures that were being proposed in the studies, the plans to report for adaptations as part of sustaining the interventions, the use of theories, models, and frameworks to help explain or plan for sustainability. And we also wanted to code or really capture the groups of actors and the contextual, the multi-levels of the context that researchers were proposing to study or engage with when assessing sustainment or sustainability. And these are just a few of the data points that we collected. Next slide, please. And so we ended up with a sample size of 72 grants in our analyses, which are studies primarily based in the United States, and with 20 studies based in at least one low and middle income country. And as part of our panel today, we'll hear more from a US-based study and a multi-country study in Latin America that were both part of our portfolio analysis. Next slide, please. And so finally, to highlight some key findings and opportunities from our portfolio analysis, out of these 72 grants that were included, 55 proposed to examine factors that affect sustainability, the majority using mixed methods. 40 grants proposed to measure sustainability, and 7 of these proposed to use the program sustainability assessment tool, or the clinical sustainability assessment tool, and we'll hear some examples of that today as well. We also wanted to capture if there were any studies that proposed to test or evaluate the impact of a strategy on the sustainability of an intervention, and found that there's only one study that specifically proposed to evaluate the impact of cancer control champions at the organizational level to sustain cancer screening. In regards to the sustainability outcome study, 31 grants proposed to measure the continuation of program activities, 17 grants proposed to measure maintenance of organizational practices or policies that were started during implementation, and then 5 grants proposed to document the adaptations of intervention components and the reasons for those adaptations. In terms of the theories, models, and frameworks proposed in these grants to explain or plan for sustainability, most of the grants reference REAIM and CIFR, with fewer grants proposing to use the dynamic sustainability framework and use PRISM as an extension of REAIM. And then finally, for the grants that examine factors within the context and what factors within the context are going to affect sustainability, a good number of the grants focus on organizational, provider, and patient or consumer level, but then fewer grants propose to examine factors that affect sustainability at the community and policy level. And again, these are just some key findings to highlight. I know I walked over them very quickly, but we're working on getting these results published soon, and we're looking forward to continuing the discussion today and beyond. Thank you for your attention, and I'll pass it over to Dr. Salou.
All right, thank you, Maggie, and it's a pleasure to be here and talk about our work and sustainability. And as David mentioned, I'm really grateful for the fellowship through MT Dirk that had a tremendous impact on my career trajectory. And I'm always grateful for Ross Brownson and Ola Proctor and others at WashU who led the training. What David did not mention is that I've also was very fortunate to be assigned to a phenomenal mentor by the name of David Chambers during that fellowship, which I'm always grateful for as well. So the content that I'll be presenting today is early findings from an R01 studying the sustainability of tobacco cessation programs at NCI designated cancer centers, and we just completed year one. So these are very early results and I'll start with no conflicts of interest to disclose. And I'll start with the evidence base for treating tobacco use in patients with cancer. There is a growing and strong evidence base that has been recently summarized through an NCI monograph on the topic. There's also clinical practice guidelines through the NCCN and others as a result of strong evidence showing that quitting smoking after a cancer diagnosis improves the likelihood of survival, quality of life, and overall health. And as typical with other implementation research questions, there's an implementation gap. And there are multi-level barriers to implementation, most notably at the system level, with inadequate reimbursement for tobacco cessation in cancer care settings, and all sorts of clinician and patient level barriers related to lower priority of addressing tobacco use in cancer care. So as a result of this implementation gap, NCI was able to develop an implementation initiative called the Cancer Center Cessation Initiative in 2017, which was part of the Cancer Moonshot program. And this initiative led to eventually funding 52 of the NCI designated cancer centers throughout the United States to implement or enhance their tobacco cessation programs. And this program was coordinated by the University of Wisconsin. And over a period of 5 years, as I mentioned, we had 52 NCI designated cancer centers that were funded. So as an economist, I was very interested in this program, particularly because there was no economic evaluation originally planned with the program. So I approached NCI and also the coordinating center, and they were willing to allow me to ask questions related to implementation costs, for which I'm grateful, and was able to work with C3I and the coordinating center at University of Wisconsin to demonstrate the cost effectiveness of this implementation effort early on. And my interest in economics eventually led to developing interest in sustainability, which led to the current grant. One distinctive feature of C3I was that even though the coordinating center did a phenomenal job of standardizing evaluation, it allowed programs to design unique programs, or allowed cancer centers to design unique programs based on their contextual factors, based on the needs of their population and the resources available. So every one of these programs was unique, although the evaluation of the program was standardized. And at the conclusion of funding for this initiative, there's been a large demonstration of impact with the program reaching more than 100,000 patients, and evidence of effectiveness with more than 20% of patients receiving tobacco treatment reporting that they have quit using tobacco at 6 months, and also benefits in terms of equity, where the reach of tobacco cessation programs increased among all patient populations, particularly among underserved populations. Part of program participation was that programs had to submit a sustainability plan to NCI, including a letter from a commitment from the cancer center director. And so sustainability was front and center from the beginning, although we know that different circumstances, including COVID, influence sustainability of these programs over time. So as we started thinking about studying sustainability, the question came up of what is it exactly that these programs should be sustaining? So At that point, we realized that we need to think about the core functions and forms of tobacco cessation programs in cancer care. So working with our experts from C3I, including many participants in the various working groups that the C3I Coordinating Center developed, we came up with a list of core functions, although we did this retrospectively, which influences our evaluation. So this was not done upfront at the implementation stage. As we started developing interest in sustainability, started reviewing the literature around sustainability. Of course, the dynamic sustainability framework came up, but also this recent article by Rachel Shelton and colleagues extending REAIM to really consider maintenance, extending maintenance as a concept of long-term sustainability and evolution across program lifecycle. Also, the iterative application of REAIM assessment to guide adaptations, which are critical in the sustainability process. There's in this extension of REAIM, there's an explicit consideration of equity and cost to address across the REAIM dimensions. Importantly, there's also certainly this is guided by the dynamic sustainability framework, and also the important link between implementation costs and sustainability. So that's we've used that as one of our guiding frameworks, as well as the fact that REAIM was guiding C3I evaluation in general by the coordinating center. And so the R01 that we have to evaluate sustainability, and this is happening now after funding has ended, is using an implementation mapping approach to link the different sustainability constructs. So we're starting with REAIM as guiding our outcomes of measurement of our outcomes of sustainability. And we're mapping these outcomes to determinants of sustainability and implementation strategies that were used by the programs to achieve sustainability. We also, as I mentioned, rely on a lot of literature over the last decade or so that has advanced the science of sustainability. And most notably was an early article by Shearer and Deering that discussed sustainability outcomes as multidimensional. Certainly there's the sustained health benefits or patient outcomes at the center, or as a centerpiece of focusing on sustainability. But in addition to that, we look at other dimensions, including continued program activities, maintaining practices, procedures, and policies within the program, maintaining partnerships, and scalability, diffusion, replication as another dimension of sustaining programs. So I'm going to share some early results that we have. So we've been able to now, in this R01, we're relying on historical data that was collected by the coordinating center during the implementation phase, as well as new data collection that we're conducting. And so these results are from a recent survey of the C3I sites, in which we achieved a 90% response rate. So we have 47 sites that have responded. 83% of them told us that they are still offering tobacco treatment service. And out of the sites that are still operating, we see that there's quite a good maintenance of core functions, which varies by function, and it's natural to see that screening is one that is the best maintained over time. And then it drops off in terms of referral and being able to measure reach and effectiveness. We also asked the sites about the different components, or some of these are forms of the program that were maintained, and it's notable the variation in terms of some of these components that are maintained over time. Most notably is the drop in maintenance around outcomes reporting and also education and training, which is expected to see that we expected to see a drop in reporting of outcomes, which can be challenging after funding has ended. I mentioned that scale up or diffusion is another dimension that we're interested in, and so we asked sites about which settings they were able to implement and these programs in. And so the lighter shade reflects a historical implementation during the first year of funded implementation versus the current state, and then the darkest bar is for where the program is expected to be 1 year from the time of the survey. So we see that most programs implemented their tobacco cessation started in medical oncology, followed by radiation oncology and surgical oncology, although we're seeing expansion and diffusion into primary care settings, starting from oncology as well as other specialties, and that's expected to increase over time. To better understand sustainability capacity, we actually started before the grant collecting CSAT scores, and this stands for the Clinical Sustainability Assessment Tool, which is an instrument also developed by a team at Washington University led by Doug Luke. And we started collecting these data during the implementation phase, before the sustainability grant was funded. And we were able to see an increasing trend in sustainability assessment over time. And also cohort 3, which was the latest cohort to be funded. Also, we saw some convergence there in terms of a faster ramp up of assessment of sustainability capacity, likely due to the network effects and the learning collaboratives that were developed by the coordinating center. We most notably also is the period of COVID that happened during this assessment, and despite this, we saw a maintenance of sustainability capacity, and then a drop off that was around the time that funding ended for most of these programs. As we started collecting CSAT data, we received feedback from sites and from experts in C3I that were still missing certain domains, and so we turned to the other tool that the sister tool for CSAT, which is the PSAT, the Program Sustainability Assessment Tool, and borrowed additional constructs or domains from the PSAT that were identified by the programs as critical, such as funding stability and strategic planning. And so we added 4 domains to the assessment that we conducted during the R01 phase. And so we have additional data now, and not surprisingly, we found that these domains of funding stability, strategic planning, which includes sustainability, developing a sustainability plan, were rated lower than other domains, including the various CSAT domains. And so we're currently wrapping up interviews with sites to better understand the circumstances and sort of the determinants of sustainability, especially at sites that reported low scores on the CSAT and PSAT. Over the past couple of years, we've also been engaging C3I stakeholders through the working group structures to really understand implementation strategies. And those were not necessarily identified originally because there was a lot of autonomy in terms of this implementation initiative at the sites. And so we went through a brainstorming exercise to come up with implementation strategies. Again, we were guided by the CSAT domains during that exercise to identify the implementation strategies and then prioritize them in terms of importance and feasibility at the sites. And then we included these in our survey to understand which ones were actually being utilized at the sites. And so this is early results of sites reporting which implementation strategies they were using and continue to use during the sustainability phase. And naturally, we also see some differences here, especially around organizational readiness and outcomes and effectiveness in terms of strategies that were less likely to be maintained during the sustainability phase. We also compared the use of those strategies between operating sites and those that are no longer operating. And so we see here in green are the operating sites versus the non-operating sites in red. And the most notable difference between the two is around organizational readiness across the when you roll up the individual strategies into the CSAT domains. And then we asked sites about financing and financing strategies, and which wasn't covered by the CSAT. We thought this was really important. And it was notable to see that 40% of sites had their highest budget was between 100,000 to 250,000. And this was, and then we asked them about maintenance of those budgets. 70% of sites were able to maintain those budgets. 30% saw a decrease in their budgets. And then most interesting was when we asked sites how much additional funding they needed, we saw that over 1/3 said that they only needed $50,000 or less to be able to really optimize their tobacco cessation programs. In terms of program financing strategies, we saw different sources of funding, although most dominant was institutional support as the funding source for these tobacco cessation programs. And we saw a slight difference in terms of operating sites having more diverse sources of funding that included billing and reimbursement for based on fee-for-service, in addition to philanthropy and grant funding. And then finally, we asked sites about the partners that they work with and that they were able to maintain during the sustainability phase. And here we saw that naturally the internal stakeholders or internal partners were rated higher, including program clinicians and staff and academic departments, cancer center leadership, followed by several internal and external partners. And with that, I'll turn things over to Ginger. Thank you.
Thanks for that, Ramsey. And so I'm going to talk a little bit about our R37 that is also still relatively new, with just we're just a year and a half in also, but it's taken a long road to get here. So I'll discuss a little bit about what that has been like. We have been supported along the way in a couple of different fashions. NCI has also been helpful in getting this work off the ground. And I have to say, I actually continue to work in de-implementation and in HIV, and I really love the two sides of the coin of sustainability and de-implementation. So maybe another time I'll get to talk about the de-implementation part of things. But we were asked to talk about perhaps if you were considering incorporating sustainability or a focus on sustainability in your work, you know, what are some of the things that you should consider, and what are some areas where I feel like there are growth? And so for me, I think it's helpful to start with where we are right now, and then I'll walk you through how we got here. So our project, the goal of our project is really to identify the key drivers or determinants or predictors of the intervention that we're interested in, called PEWS. And we think of that set of determinants as clinical capacity. And then we're interested in also in alignment with Ramsey of strategies that can help use sustainability in a global setting. And so one of our first key issues was, how are we going to conceptualize this? This is in a clinical setting, and so we use the model, and the work of our group here at WashU has worked to develop this model of clinical capacity for sustainability, or the ability to maintain structured practices over time, and that this is the key driver of intervention sustainment, or the ongoing use of an intervention with fidelity. And this set of determinants has multiple domains that we can measure. And we hypothesize that hospitals in our situation starts with a certain level of capacity. They go to implement an intervention. In the process of implementing that intervention, capacity might change or adjust. Simultaneously, the intervention may be adapted to have better alignment with capacity, and that hopefully through that alignment, sustainment is achieved, and that ultimately the recipients of that intervention continue to receive benefits. However, in alignment with a dynamic sustainability framework, we've also influenced our thinking. We know that this isn't necessarily a static issue, that capacity and the intervention itself may fluctuate over time. And so to explore these relationships, we have set up a prospective observational study with approximately 100 hospitals that are in various stages of implementing, although the lion's share are in a sustaining phase. And the key point here is that we are capturing hospitals where they are at. And we're collecting a couple of different data points from them. One, their capacity. Two, their reported intervention use, or PUES use, and the patient outcomes. And both of those are coming from the patient record. In the effort to identify strategies that might be effective in supporting sustainment, we also will have a qualitative data collection effort that will hopefully start in the next few months, where we will be comparing sustaining and non-sustaining hospitals through a series of focus groups with nurses, doctors, and administrators to identify those strategies and how to, affect change. There's a QR code if you're interested. I'll have those all along the slides in case you're interested in taking a deeper dive into anything that we have spoken about. So I'll give you a little more information about the thing or the intervention that we are interested in. But to give you a global context, in America and the global north in general, about 80% of children will survive with cancer, and which is a pretty great outcome. It's improved tremendously in the last several decades. However, only about 20% of children in low and middle income countries or the global south will survive. And so St. Jude at large and my awesome colleague Asia, who can't be here today, have worked really hard to improve access to cancer treatment for children. And one of the secondary issues that has come along with that is that, and one of the things, as an aside, one of the things I love so much about being an implementation scientist is you get to learn about all these different clinical areas. And I have learned that with improved access to treatment, that treatment is very toxic. And so it's important that alongside that access comes supportive care. And that's what this intervention PUES is about. And the way it works is it's primarily used by nurses It's done as an assessment with every clinical assessment, bedside assessment that a nurse does with a patient. It involves a scoring tool that you use, and you assess the patient, and then you add up their score, and then you use that score to make a decision using an algorithm that determines whether or not you should encourage additional supportive care for that child. And we know that it improves outcomes for children all the way from needing less intense care, improving effective time to care, and preventing death. So the primary way that St. Jude has worked to implement this globally in low resource settings is through what I would describe as a quality improvement collaborative called Proyecto EVOT. You'll hear me use EVOT and PEWS interchangeably from now on. They're the same thing. It's just depends on whether you're thinking in Spanish or you're thinking in English. It involves, at this point, approximately 100 hospitals and a variety of hospitals, including like oncology centers, pediatric hospitals, women and children's hospitals in multiple countries. And they have a cohort model where about 10 to 15 new hospitals join each year. And this is what it looks like from the perspective of a single hospital going through this process. It's started through planning and establishing an implementation team. They do a very small pilot. They then move on to a wide-scale implementation. Once they're fully implemented, there's a follow-up period called early sustainability here, where they work closely with St. Jude and monitor their outcomes closely to make sure that they're achieving the intended outcomes. And then once they complete that follow-up period successfully, they are in full sustainability mode where they have very little interaction with St. Jude, support from St. Jude, although they may continue to engage with the collaborative. And what we have done is we have layered in data collection at multiple phases of implementation, as well as routine follow-up once they hit the sustainability phase. And so one of the early issues that we had to address with this project is our intervention sustained or is it not? Is it a problem or is it not? And one of our first cross-sectional studies showed that in fact not all individuals are using PEWS all the time at every bedside measurement. And also, hospitals as a whole are not always sustaining PEWS sufficiently. And so, and what's interesting as well, in alignment with the dynamic framework, is that we're not always seeing the hospitals from time point. Sometimes hospitals, bounce back and they achieve good sustainment. Sometimes they don't. Sometimes we see hospitals completely fall off the map as well, where they basically are going to need a complete relaunch of the program. Furthermore, we also see adaptations happening in that sustainability phase, although, and we hope to have a paper coming out about this specifically soon, that we think that largely people are doing it in such a way that it's not affecting the efficacy of the intervention. So then the next issue I would argue that we've had to deal with is how do you conceptualize and operationalize these concepts? So fidelity, or rather sustainment for us means that the individual nurse is using PEWS at every bedside, that they're adding correctly, and then they're correctly using the algorithm. We then aggregate that up to the hospital level. And for hospitals to achieve implementation completion and move on to the sustainability, phase that has to be using pews correctly 15% of the time or better. And so if a hospital as a whole drops below that, they're considered not sustaining. If they're better than that, they are sustaining, although individuals might vary in their success. And so for you in your own work, that might look different in how that is defined and operationalized. We have also worked to establish evidence of the relationships between these concepts. And so again, that first study that I mentioned, the cross-sectional one, we were able to show that capacity overall was the predictor with the, or not predictor, excuse me, was had the best evidence of association with reported sustainment, although there were a couple of other determinants that were significant, which we continue to keep an eye on in our longitudinal study. And then we have grappled with lots of design, data collection, and measurement issues. So I mentioned that this is a cohort study, essentially, where we have started to capture and collect data from people where they're at, which is going to be wonderful. I hope long term we have followed hospitals for a bit of time, and we're able to now examine some of the dynamics in this sustainability phase. But we have talked extensively about what the right timing is for data collection. And so for us, that is when hospitals reach significant milestones in their implementation. And then once they're finished and in the sustainability phase, that's every 6 months. For you in your own work, that timing might be different, and the spacing might be different. And what kinds of data do we actually need to capture? We have our key determinants, which is the clinical capacity, but and I mentioned how do we operationalize sustainment. But in addition to that, particularly in the realm of patient data, how much can we trust that if you use pews, it continues to be effective, or do we need to keep monitoring the effectiveness of this? And where we have landed is that we have whittled it down to the bare bones indicators of effectiveness. And that balances for us our analytic needs so that we can continue to answer our questions that we need to be able to answer, but also reduces the data collection burden for our hospitals significantly, which I think is really important to consider in a low resource and global setting. And I see the questions coming in. I will definitely speak more on this issue. So we've also had a measurement issue with our clinical sustainability assessment tool, which is our primary determinants measure. Because we are doing this in a global setting, we are working in multiple languages and multiple cultural contexts, primarily Spanish and Portuguese. And so through our pilot work, we translated the CSAT into those languages and piloted them with the sites and demonstrated good concurrent validity. However, like I mentioned earlier, Pews is relatively simple. And given the particular setting that we are working in, we felt like that concurrent validity was sufficient. And in communication with the Proyecto IVA steering committee. But I would argue that there may be some concepts and interventions where the cultural variability and how those things get interpreted and thought about is important and should be considered for your own work. Okay, and then looking forward to strategies, I mentioned a qualitative data collection effort to do that. However, we do have some preliminary evidence that hospitals are developing their own local strategies, and we hope through this work we can elevate some of those strategies that will help maintain sustainability of PUs. And but we will also try to look for and generate new ideas with our hospitals. And so we have grappled, like more than I really even care to admit, we have grappled with what is the right selection criteria for our hospitals. And for us, this will be whether they're sustaining or not. And on the recommendation of our steering committee, the hospital structure. Okay, and to sum it up for you, things that you should consider before you dive into this avenue is the intervention, how it's being sustained, how you define that, and how is it being adapted. Ours is relatively simple, but yours might be more complicated. What are the conceptual relationships that you should be considering, and what is the evidence for those determinants or drivers of sustainment? What's going to be your design, and what is the right timing and burden and follow-up period? And then how will you identify and develop those strategies? So if you want to talk about these issues with us, we love to do that. We are at the Center for Public Health Systems Science. However, if you have a clinical question, I can't answer that. You would have to talk to Asia, and you can find her in the QR code on the right. Thank you.
Thanks so much to the three of you. As you can see with the next slide, we're happy to entertain questions, and we just want to thank those of you who have already been providing questions. So we're going to see how many we can get through before the top of the hour. Wanted to go back, Maggie, there was a question that folks were curious about from the review, and then I'd like to extend that into a question for others as well. And so the specific question was whether the analysis looked at the length of time considered when studying sustainability, months versus years after implementation. So Maggie, did you want to just quickly comment on that, and then I'll have my follow-up?
Yes, thank you, David. Yes, indeed, we coded for that. So we have information on when the grants are proposing to follow up. So we have data from anything between 12 months, 18 months, 24 months, and sometimes at multiple time points. And we also try to capture that as well. And all that would be in the final publication as well. But yeah, that's definitely a data point that we collected.
Perfect. And then maybe for Ramsey and Ginger, for each of your studies, how did you get to a particular time point from which you thought, okay, at this point, we're talking about sustainment? I know, Ginger, you had mentioned there's sort of early sustainment and sustainment. And Ramsey, I know that your effort has been looking at sustainment. So curious if either of you want to share your thoughts about at what point something sort of transitions from an implementation phase to sustainment and how you derive that. Ramsey, did you want to start?
Sure, I can start. So for us, it was because it is mostly an observational study. We don't have control over the implementation or sustainment of these interventions. We are dictated by what we observe, and we're and mostly retrospective data. So for us, the switch is the end of the funding from NCI to these programs. So we considered roughly the implementation phase around the timing that the programs had funding from NCI, and then that's when the switch turned to sustainability phase. Although that's not as easy to quantify sometimes because we're studying this retrospectively. There's also, and the fact that the funding was staggered across the programs. There was also variation in the length of funding that programs received. Cohort 3 received less time than funding for less time than the other programs. And there was the complication of the fact that some of the programs that were funded already had programs in place. So this was more of enhancement rather than initial implementation. But essentially for us, it was somewhat easier because we had the funding, and then there was the grant funding ended, and there was a clear cutoff.
Gotcha. And Ginger, how about you?
Yeah, so that early sustainment period, there is still, that's like your traditional follow-up period. So they're still pretty continuously sending information to St. Jude and working with St. Jude to make sure that they're maintaining sufficient fidelity. After those 18 months are up, then the connection is cut. And so that's the definition of sustainment for us, of where we consider them having moved on. And that draws from a lot of the literature, similar to you, Ramsey, where once the support for implementation has been removed, can organizations continue?
Gotcha. So another question that had come up, and Ginger, I think this started from your presentation, is just folks are interested in what strategies can be implemented to maintain site engagement and ensure the consistent data collection during that sustainment phase, which I know is a challenge.
It is a challenge, and I really have to compliment the St. Jude side of our team, who works really hard to engage and maintain a connection with those ever growing number of sites. And they have quite a few strategies on how they do that they could talk about, how they do that. I would say another thing that we do is that we take whatever data we can get. Sometimes sites come to us and they're like, well, we can do some, but not all. And we just say that's okay. And that has helped as well. And again, that data burden collection issue that I raised is another strategy. I think as investigators, I'm certainly constantly combating this feeling to collect as much data as I possibly can, out of some sort of fear that I won't have a result, and resisting and really keeping it to the absolute minimum. And I think that helps, as well as making it manageable to participate in the study for the sites.
Gotcha. Ramsey, any thoughts there about strategies to maintain the engagement with all the sites?
Yeah, so from the site perspective, I would say the easy answer to that is designing for sustainability. So I think, in the case of C3I, sites that were able to design reporting systems and data monitoring systems that were meant to be sustainable and had low maintenance over time were successful at maintaining their reporting capabilities. Although there are, other external factors, and then certainly there are system level determinants of that, right? So if there were mandates for reporting, which there are not in this case for the outcomes that we're interested in, then that would certainly make it more sustainable. So a lot of C3I stakeholders call for, in the absence of mandates from the healthcare delivery side, they call for NCI, for example, to be able to include that as a requirement of cancer centers in terms of reporting these outcomes moving forward. That would certainly make it more sustainable. And then I'll mention that within our research team, and I'm sure this happens a lot, is that we've had an internal debate about whether strategies for sustainment or sustainability strategies are a unique set of strategies compared to just broad implementation strategies. So in this case, these implementations, and I think there is some uniqueness to designing reporting strategies for sustainability in this case versus the regular implementation strategies.
Right. So I'm seeing a couple of different questions that are really speaking, I think, to this idea of the core components of an intervention versus potential adaptations. And I think each of you at different points mentioned adaptation. So maybe I'll take one part of this thing. So for the different, whether it's Maggie, in the review that you did, where you were taking a look at what folks within the portfolio were defining as far as core components of an intervention versus adaptation, how clearly defined is what parts of the interventions are necessary in order for it to be considered sustained? And then maybe if we would shift to Ginger and Ramsey, talking about for their interventions, how did they see, the core remaining functions versus anything that might, not be. So Maggie, do you recall just how different studies were trying to operationalize that?
Yeah, so very broadly, it depends on the intervention for sure. Like some are definitely at a stage where there are adaptations that are feasible and are considered as part of the study. But then, yeah, very few studies overall even brought the idea of considering potential adaptations for any aspect of the intervention that was being studied. So it was, I would say, definitely a gap in a way that there is that need to, if needed and if relevant for the intervention, to bring the conversation around adaptations. Yeah.
Gotcha. And then Ginger, how you tried to find that core components versus adaptation?
In a lot of ways, that's sort of already been laid out for us, and that's why I kept mentioning that Pews is relatively simple. You just have to do it at every bedside visit, and then you have to add right, and then you have to follow the algorithm. But I will soon be involved in another study for an intervention that is far more complex, and so so in the instance of our intervention, it's not terribly complicated, and although and I'll also add that sites during implementation are encouraged to make adaptations to this intervention in terms of like making it language appropriate, to make the algorithm align with the resources that are available to them in the hospital, because I mentioned it's lots of different types of hospitals, and so it's a bit more straightforward for us, but I don't think that that's true all of the time.
Gotcha. And Ramsey, in your experience, that same issue of fidelity versus adaptation?
Yeah, so I mentioned in our presentation that we defined core functions after the fact. We realized how important it was to define that, but that was unfortunately after implementation. And perhaps it's also because smoking cessation is and smoking cessation programs are so common that it's sort of assumed that we know what the core functions are. But in every setting, there are subtle differences, and we still had very active debates and discussions about this with our group of experts as we were going through the exercise of defining the core functions. So some of this, so for us in terms of measuring fidelity, some of this can be captured from the data that was collected by the coordinating centers in terms of the site surveys. Also, although there was an attempt to balance response burden in those surveys, and including our survey as well. So we have some information about this, and although it's not precise enough in every case to really tease out fidelity, we also have an opportunity to do that with the interviews, which we are doing. We are using the frame as a guide to measure adaptations, and so we are looking at questions about whether there was fidelity to the core functions that we defined after the fact, but most of them are common in smoking cessation. And we're also looking at the question of whether the adaptations were planned versus unplanned. And we also had COVID was a big factor in during our implementation phase.
Great. Well, thanks to each of you. I see that we're right at the top of the hour. I'm going to pose maybe thanks to the three of you for your wonderful presentations, and everybody who answered questions or asked questions, and I got great answers. So with that, maybe I'll turn it over back to Denise to close us out.
Sure. So thank you again to our presenters and the audience for your participation. I did drop a link to register now for part 2 of this series, Increasing Scale-Up Research in Cancer Control. That'll take place on October 8th. The archive of this website, or sorry, of this recording will be on the IS website in the coming weeks, and the link is also in the chat. We look forward to seeing you all at the next Implementation Science webinar. Thank you.
U.S. Department of Health and Human Services, National Institutes of Health, National Cancer Institute, cancer.gov, 1-800-4-CANCER.